I'm I'm Dr. Janakiraman Subramanian. I'm a medical oncologist at St. Luke's on the Plaza. And today I'll be talking about immunotherapy and its role in cancer. Sorry, there we go. So this slide has been reviewed by another MD. And these are some disclosures. And as I said, I'm Janakiraman Subramanian. I do have some disclosures that I've done consulting and speaking for some of the sponsors of this program. So in terms of what we are going to discuss today, we are going to go through certain topics. Obviously, the first one is introduction, and then, the big question, what is immunotherapy? The question that follows that is immunotherapy right for me? And what, as a patient, one should know about clinical trials, the types of immunotherapy that are available, and their potential side effects, as well as if you undergo that treatment, what can we expect with the quality of life, as well as the future for immunotherapy. And that'll bring this discussion to an end, and we'll have some questions and answers after that. So what is immunotherapy? The name itself is somewhat obvious. It is essentially a treatment that uses our own immune system to treat cancer. And as many of you might know, the immune system is designed to attack a cell which it sees as unhealthy or abnormal. And that's what we are leveraging when it comes to in immunotherapy. Along with immunotherapy, another term that you may all run into is something called immuno-oncology. Now, this is the field of cancer research that works to understand our immune system and how it interacts with cancers, and how we can use that relationship to treat or even prevent cancer. So what is the immune system? The immune system is not one single organ. It's a broad coalition of tissues, organs, cells that all come into play. Even our skin is a very important part of our immune system. And what it does, it tries to recognize and destroy or stop a foreign substance, such as a bacteria or a virus, and prevent that from establishing itself in our body and allow that to multiply and grow in our body. That's what it tries to prevent. And the way it does that is there are several methods. And one of the important ways it recognizes these foreign cells is by certain protein markers on them, which we call antigens. So continuing on that, the way we use immunotherapy treatments to fight cancer follows certain broad pathways. One is sort of non-specifically boosting the entire immune system. We're not making the immune system target any one particular cell or anything like that, but it's just like overall boosting the immune system and allowing it to be sort of hypervigilant. And this is sort of the old techniques that we used to use in the treatment of like melanoma or kidney cancer in the past. We don't use that as much now. The more newer methods are where we are marking the cancer cells by a certain protein target on them, and then allowing our immune system to recognize them and target them. And these are some of the newer treatments that we are currently using in the clinic. Also, the immune system can be used to find the cancer cells and deliver certain treatments like chemotherapy or radiation directly to the cancer cells. This is more like a very smart chemotherapy where it's not given to to target all of the cells in the body, but more specifically to the cancer cells. That can also be done using the immune system. Generally, immunotherapy is given as an IV infusion. or sometimes we give it as a subcutaneous injection. So it's not usually a pill. It's usually an injection, and it's given in a doctor's office. Sometimes it is given by itself, or it could be given in combination with other treatments, including chemotherapy. So what is the immune system, and what constitutes the key components that are part of our immunotherapy? Now, as I said, the immune system is not just one organ. It's network of cells, tissues, and organs. And then in the immunotherapy, you will consistently see a few terms come around. One is the T cells. Now, T cells is just a type of white blood cell. And it's one of these cells that attacks any of the foreign cells or substances that invade our body. So these are the enforcers or the soldiers of the immune system. And antibody would be another term you would run into as well if you do your research on immunotherapy or immune system. Essentially, this is a protein that is made by our body that allows us to recognize certain invaders of the system like bacteria or viruses by tagging onto very specific proteins on these cells. And what that protein is called the antigen. So that interaction is between the antigen on the foreign cell and the antibody that binds to it. And a tumor antigen is a protein that is very specific to the tumor cell. So when antigens can be present on infections like bacteria, viruses, as well as cancer cells. So the ones that are present on the cancer cells, we use a more specific term called tumor antigen. Biomarkers. Now, many of us that know something about cancer would know about biomarkers. These are any molecule that gives us very specific and directed information about the cancer. Some important things to know. When you're on immunotherapy, if you have any side effects, it is best to run that by your healthcare team because what we generally know about chemotherapy does not necessarily apply to immunotherapies. Plus, these are new treatments. And therefore, when we experience a side effect, which is something that's persistent, not improving, do not make any assumptions on your own. It is better to get the healthcare provider on board so that they can help better understand what to do. Despite some of the major progress we've made in the use of immunotherapy against cancer, it is not for everyone. There are cancers in which immunotherapy is ineffective, or we still haven't developed the right immunotherapy. So again, not every cancer patient is a candidate for immunotherapy. And generally, they are better tolerated, particularly some of the ones that we use in the clinic, but side effects are well known to occur, sometimes can be very severe. And so we're still learning a lot about immunotherapy as we use them in the clinic. So some of the key research questions that are being addressed in the use of immunotherapy is what I mentioned before. Why do some patients respond so well to immunotherapy and not at all in others? This is an area of active research. In fact, there is some progress made. Some tumors seem to be very immune active. Others are what we call the immune cold tumors. So that's an ongoing area of research, including at St. Luke's as well. We are actively exploring and trying to answer these questions. Some of our research has already been presented in major conferences. The other questions that we are trying to address is, these treatments do work well, but can we deepen their response? Can we get a better outcomes by combining it with other treatments? This could be other immunotherapies or chemotherapy treatments as well. So all of that is being investigated. Also, we are trying to understand when would be the right time to use an immunotherapy, also whether there are long-term side effects. Even though we now have been using immunotherapy for 10 years now, still in overall our knowledge of medicine, this is a very short interval of time. and therefore long-term side effects are still being studied for these agents. So as a patient or a caregiver, one of the first questions arises is that, is immunotherapy right for me? So who might be eligible? In general, most patients who have cancer, are not necessarily eligible for immunotherapy. But where we do use it is patients who have advanced or what we call metastatic stage, which is either like stage 3 or stage 4 cancer. We are also now moving towards using immunotherapy in the early stage cancer. As an oncologist, I predominantly treat lung cancer. Only like last month, the FDA approved an immunotherapy treatment in patients who had surgery for the lung cancer. These are patients who have early stage cancer, like a stage 2 lung cancer, and if they have undergone surgery, now in some of those patients, immunotherapy could be an option after surgery for them. Also recently, we are seeing this in other cancers like melanoma, even in kidney cancer. There are immunotherapy drugs that are now being explored in the early stage setting. Also, people who have immune-mediated diseases, what we call autoimmune diseases like rheumatoid arthritis or lupus, may not be candidates for immunotherapy. Also, some patients who've had organ transplants, like a heart transplant or a liver transplant or a kidney transplant, are absolutely not candidates for immunotherapy. Also, patients with multiple sclerosis or some of those conditions where we limit or completely avoid the use of an immunotherapy treatment. So once again, if you think immunotherapy could be right for you, discuss that with your oncology team, and they would be the best people to guide you on whether such a treatment could be an option for you. Inevitably, this question always comes, what does it cost? Unfortunately, too much. Most of us on our own cannot afford these treatments. Thankfully, these treatments have shown significant enough benefit that when we do offer them to the patients, many, if not most times, they are approved by your insurance. Now, of course, some immunotherapies are only available on a clinical trial because, as you know, this is a constantly evolving area, and so clinical trials are a big part of it. So if you are a candidate to go on an immunotherapy-based clinical trial, what are the options in costs might be a big question. Now, once again, your healthcare team can help address that. Obviously, not everyone on your healthcare team is as knowledgeable as some of the other people. For example, myself, sometimes when patients ask me this question, I don't know the exact answer to it. I know it is expensive, but what we can do is find that person, which is usually someone in our billing department or our social worker or both of them, that can help address these questions better for you. Also, your healthcare plan can answer some of these questions better. In some situations where patients have not been able to get insurance coverage, we have been able to find access programs to allow them to receive treatment as well. And inevitably, this question also comes after that, which is, am I a candidate for a clinical trial? Once again, I would actively encourage patients to look to participating in clinical trials. But at the same time, each patient is different. Some patients may not be candidates for clinical trial. This may be because there are no right clinical trials for them at that center, or because they don't meet some of the eligibility criteria for those clinical trials. So there may be trials at other places that they may be candidates for. In some situations, some patients are too weak to participate in any clinical trials, or they may have a very complex scenario which most clinical trials do not cover. So again, your care team would be the key people to answer that question for us. So in an institution like St. Luke's, it's the team does not involve just the physician, but the nurse practitioner, medical assistant. On top of that, the social worker, the research team, all of them come together to answer some of these questions for us. So if you are found to be a candidate for a clinical trial, many patients ask me, am I going to be receiving placebo or no treatment at all? Now, in general, for almost any clinical trial in oncology space, we do not give just placebo alone for treatment for patients. And if we do, it's very clearly stated before. Most of the times you will get in fact, almost all of the times, at the minimum on a clinical trial, the patient who's enrolled on it will get what is considered standard of care for their type of cancer in that particular setting. On top of that, they may or may not get the study drug that is being evaluated. So that's how almost all oncology clinical trials are designed. And that's very intentionally so, because there are several regulatory agencies that oversee them, and there are clear guidelines that you cannot offer a substandard care on a clinical trial for a patient. Not in this country, not in the kind of clinical trials that we do in any respectable oncology program. If it is a patient's on a clinical trial, we cannot offer anything less than what is standard of care for them at that time. Of course, when you're on a clinical trial, we talked about the cost and billing issues. In general, it's a partnership between the study sponsor, which is usually a pharmaceutical company, and the insurance payers, because your study procedures, including treatment, is paid for by the companies, the sponsor, and the rest of what is called the standard of care will be paid for by your insurance payer. So moving on from that, what are the types of immunotherapy that one can potentially receive? There are several, actually. Now, there is a long list here. One of the more recent arrivals is this checkpoint inhibitors. We'll be talking about them. Also, there are others, what we call monoclonal antibodies. I told you antibodies are proteins that target specific proteins on cells, which could be your cancer cell or your infection cell, your bacteria. And then there is something called cell therapy. Many of you might have seen CAR T cells or heard about them. That is what cell therapy means generally. And then we have other treatments like cytokines. One of the things I talked about is boosting the overall immune system, not targeting a particular protein, but boosting the overall immune system. And one of the ways we do that is using something called cytokines, which we normally produce in our body, except we give more of it to boost our immune system. And then there are cancer treatment vaccines and also what we call an oncolytic virus therapy. So what are checkpoint inhibitors? So as good as the immune system is, we don't want the immune system to run rampant. Once it starts to attack an infection, we don't want it to go out of control and start attacking the rest of the body. And so there are some safeguards within our system that stops the immune system from running rampant, uncontrolled. And these are called the checkpoints. And sometimes these checkpoints, which play a very important role in protecting the rest of the body from an immune reaction, are sort of hijacked by these cancer cells. They then trick the immune system into shutting down against them so that the immune system does not target them. Now, these checkpoint inhibitors block these tumor-specific checkpoints, allowing the immune system to target the cancer. One of the recent checkpoint inhibitors are these PD-1 or PD-L1 inhibitors. And as you can see in the cartoon on the left side, you'll see the blue T cell trying to attack the tumor cell in purple. And you can see on the top, there is the T cell receptor binding to the tumor antigen, which is the standard method by which the T cell tries to recognize the cancer cell and attack it. Except at the bottom, you see that the tumor cell is using a checkpoint called the PD-L1 to connect with the PD-1 on the T cell. And that tells the T cell to shut down and not attack the tumor cell. So it's hijacking a normal checkpoint here. Now, when we use these PD-1 or PD-L1 checkpoint inhibitors, these are antibodies, which you can see these Y-shaped molecules on the right side panel, and at the bottom part between the interaction between the PD-L1 and PD-1 essentially stops that interaction from happening. So once that interaction at the bottom branching point from the T cell and tumor cell is blocked, now the T cell is activated against the tumor cell and starts attacking and killing that tumor cell. And this treatment has been found to be effective in a variety of cancers. So in fact, there are a variety of PD-1 and PD-L1 inhibitors. Many of them you might have seen on TV ads. Currently, there are 6 of them available. And of course, once again, they are not for every cancer that we see, but they are used in a wide variety of cancers. Common ones like lung cancer, liver cancer, head and neck cancer, colon cancer, even breast cancer, there is some role for immunotherapy, as well as some of the rarer types like Merkel cell. Once again, we have that. Also, one of them called pembrolizumab, or the brand name being Keytruda, PD-1 inhibitor, is approved for any what we call solid tumor that has a specific biomarker, which defines it as whether it is MSI or microsatellite instability high or mismatch repair deficient tumors. Now, these are complex terms, and you may not know whether your tumor belongs in that category. But if you don't know, it's best to ask your oncology provider to tell you whether you're eligible for such a treatment as this. Now, once again, even in some cases where you have MSI high tumor, you're not automatically a candidate for pembrolizumab, because there are several other rules that have, several other criteria that has to be met, clinical criteria that has to be met before we can start such treatment. So going in alphabetical order for these immunotherapies, the first one is avelumab. This is one of the newer ones. It is approved in the treatment of Merkel cell carcinoma, which is a skin cancer, which is a type of skin cancer, and also it is used in bladder cancer. Pembrolizumab, this is one of the older checkpoint inhibitors and one of the quite effective ones. As you can see, it's been approved in a variety of cancers here, and it actually continues to grow, the number of indications. The other one is nivolumab. Pembrolizumab and nivolumab, many of us might have seen advertisements. Once again, it kind of came out along with pembrolizumab. Once again, you see a long list of cancers in which it is approved. We have a lot of experience using both of these agents. The other one is atezolizumab. Obviously, these names are not easy. So it's always a challenge for us to remember all of these names, but we've gotten so used to them now. So atezolizumab, as a lung cancer doc, I used it a lot, particularly in my small cell lung cancer patient, but it's also approved in bladder cancer and breast cancer too. The other one is Imfinzi. Imfinzi or durvalumab is approved in primarily in lung cancer, both small cell type and non-small cell type. Cemiplimab is one of the newer arrivals. It was initially approved in skin squamous cell carcinoma and basal cell cancer. Now it's also approved in a specific subtype of lung cancer. Ipilimumab, unlike the ones that we talked about, which were PD-1 or PD-L1 inhibitors, it's a different checkpoint inhibitor. This checkpoint is called the CTLA-4. This is one of the oldest checkpoint inhibitors to become available. And it's currently approved in melanoma patients, as well as in some kidney cancer and colorectal cancers. Also some other cancers like mesothelioma, lung cancer also, there is approval for this, but usually in combination with another checkpoint inhibitor. So as I said, something like ipilimumab, we commonly use this in combination with other checkpoint inhibitors. Also, sometimes we give these PD-1 and PD-L1 inhibitors with other chemotherapy agents. What about other monoclonal antibodies? In fact, before these checkpoint inhibitors became available, we used to use a lot of monoclonal antibodies. We still use them in a variety of cancers, head and neck cancer, colon cancer, lymphomas. Essentially, these are all antibodies. Checkpoints, as you know, are targeting these specific checkpoint proteins. Monoclonal antibodies is a more generic term, and there are several of them designed to target specific proteins depending on the type of cancer that we are targeting. And for example, there's a bunch of them that we use in what we call blood cancers or leukemia, and there are several of them approved there. One of the common ones some of you might have heard of, which is not on here, is something called rituximab or Rituxan. And then there are these as well in blood cancers as well. Well, there's Rituxan at the bottom near CLL. Again, in certain lymphomas, Hodgkin's and non-Hodgkin's, also in myeloma, for a long time in hematologic malignancies or blood-based malignancies, myeloma was the one that did not seem to have a monoclonal antibody, but even there, we have a lot of progress, and these drugs are now a significant part of our standard treatment. Boosting the immune response. How can we do that? One way is something called cell therapy. In cell therapy, what we do is we take the patient's own immune cells, particularly what we talked about, the T lymphocytes, which are the soldiers of our immune system that are directly involved in attacking cancer cells. We take them out and we basically modify them to target the cancer cells specifically. So before these patients undergo before they undergo full treatment for their cancer, they collect these cells, modify them, give them some more anti-cancer treatment, followed by these CAR T cells. And they go in and basically target the remaining cancer cells. Now, as you can see, there are at least 2 of them now approved. One is Kymriah, the other one is Yescarta, and they are now advancing these treatments into solid tumors as well. Now, of course, that is still in the research phase. The approved CAR T cell treatments are only in leukemias and lymphomas, but they're actively exploring them in solid tumors as well. The other way to boost your immune system, I mentioned cytokines. We all have them. Whenever we have an infection, we get a fever, and that fever is caused by the cytokines. That happens because they boost their immune system. Commonly, the ones that we use are called interleukins or interferons. In fact, we've had them for several years. We've used them against very specific cancers like melanomas and kidney cancers. The reason that they are not so well known is that many times these require very specialized centers to give these treatments because they are hard to tolerate, can have some side effects, but they can also be very effective in certain cancers. And so it's not something we use in a widespread fashion. But this is an option for some patients with melanomas and kidney cancers. Vaccines, we know what vaccines are, particularly in this COVID times. We've all had a lot of learning to do about what vaccines are and what they do. And essentially, the idea of a vaccine is to teach the immune system to recognize the problematic cells. And one of the common treatments that we use is in prostate cancer called Sipuleucel. Once again, this is about teaching your cancer cells your own cells to target cancer by teaching them about the cancer antigens. Also, apart from just vaccines to treat cancer, vaccines against certain viruses like HPV or human papilloma virus or hepatitis B virus play a significant role in preventing future cancers. So that's an important vaccination to consider, particularly HPV in our younger folks, and hepatitis B vaccine too, pretty much in anyone. The other immune treatment that we have used for a very long time is BCG. Now, BCG was used as a vaccine for tuberculosis, but we use that to treat bladder cancer as well. And this is done usually by your urologist, and they directly inject it into the bladder through a catheter to generate an immune response within the bladder to treat the cancer. These are used in some very early stage bladder cancers. Oncolytic virus therapy, this is a very novel therapy, but again, used in very specific indications where the viruses are inserted into the cancer cell and they replicate and burst out of the cell, killing the cell in the process, and then going on to infect other cancer cells. And these viruses are specifically targeted to those particular cancer cells. So they don't infect the rest of the body. And we already have such treatments available, particularly in melanoma treatment, where this is injected directly into the tumors by the surgeon or dermatologist for such treatments. And they're also being explored in other types of cancers as well. Possible side effects. So, immune therapy leverages our own immune system against the cancer. But that does not mean there will be no side effects. Even though our immune system is natural to us, it can cause some side effects. In general, like checkpoint inhibitors that we give as an outpatient in the clinic are, for the most part, well tolerated, but many patients can have some side effects. Usually these are mild, could be like inflammation of the skin, which causes itching, or inflammation of the muscles and joints, which causes some pain, sometimes some diarrhea because of inflammation of the colon, but pretty much any organ can be affected. In most cases with immunotherapy, we stop the treatment, take a short break. Even the more severe side effects, or treat them with steroids, they get better. But at the same time, there can be severe side effects, particularly when we were talking about like the cell therapy or the cytokines. They can have some severe side effects. For example, the cell therapy with CAR T cells, we don't do them as an outpatient. This is done as an inpatient, many times in the setting of an intensive care unit, so the patients can be closely monitored. As I mentioned, these are some of the common side effects like rash, itching, muscle pain, all of that, and also flu-like symptoms like fevers, cold, chills, and headaches, very similar to what we would experience if you were infected by the influenza virus. Less common, but sometimes serious side effects, as we talked about, could be the GI side effects like diarrhea. Also, sometimes hormone function like thyroid function can be affected. Some patients may require thyroid hormone, other patients may require insulin. So those are some of those things that we may need to watch out for. Also, lung inflammation, pneumonitis can be a side effect. So what can we do? This is a very common question my patients ask, like, is there something I can do, like exercise or follow a specific diet that could make a difference? Unfortunately, our knowledge has not grown to that level to tell you, yeah, you can do this so that that'll mitigate the effect. I think we're learning along the way. Right now, I think you need to monitor them closely. And if any of them are getting significant enough to affect your quality of life, you need to definitely talk to your provider. In fact, even if it is concerning or you're not sure, make sure you ask them. That's what I would say. And if you're concerned about any other medication you're taking and you have questions about it, make sure you run it by them as well, so that whether that needs to be stopped or changed or adjusted, they can help you with that. Quality of life. Now, we do all of this not just to make the cancer shrink down or we have these treatments so we got to give it to them. No, that's not the whole point. It's all about quality of life. And we want to make sure that these treatments improve the patient's quality of life. And one of the important things that we all strive to improve is managing the distress that comes along with cancer. Now, when you see your doctor and they tell you your cancer is under control, it is shrinking, it's improving, or we don't see any evidence of cancer, that always helps with the distress. But that alone may not be enough. And distress can come along in many ways, sadness, anger, anxiety, all of it. And there are no easy solutions around this, but at the same time, we have a lot of options available. I think the first step is to accept that cancer is a tough disease, and distress, however strong the person may be, is we all experience that. And be open to acknowledging that and then finding the services that you may need to help with that. And your care team would be the first start. And most cancer centers now have a variety of cancer support available for them, including like efforts to manage stress, which could be something like mindfulness meditation, other techniques, exercise, and there are like coaches and exercise programs that can help. And many times the cancer center makes it available, including at St. Luke's. So this is what I was talking about, being open to the fact that this is a part of what we are going through, and be open to accepting help from others and asking for help. So other supports that are available are support groups, online chat groups. In fact, one of my patients has created for a specific type of cancer support groups since it wasn't available, but there are several of them available, and they can be a support community, not just for the patient, but also for the care provider. Family, of course, plays a very significant role, but these other support groups can also be very important as well. Going through the journey of cancer, there are ebbs and there are lows and highs as we go through the journey of cancer and cancer treatment. And what works at one time may not be necessarily the same thing that works subsequently. So once again, we need to rely on our relationships. We need to focus on our own well-being. That means our physical well-being as well as our emotional well-being. And our emotional health, we need to find the support that can help that in each particular situation. So moving on from that, where is immunotherapy headed? Now this, it says an exciting future, and it absolutely is. As an oncologist, 10 years ago, when I came to this field, we had very little to offer for our patients. In fact, I remember still every clinical trial with an immunotherapy bit the dust. But now, not only do we have successful and effective treatments, in fact, we are further developing newer treatments that are showing a lot of promise against cancer. Novel ways to even better target these cancers, newer checkpoint inhibitors, better cellular therapies. And in fact, from checkpoint inhibitors, we are moving towards antibodies that bring the T cells directly to the cancer cell, what we call T cell engagers. So there is so much promise to this field that it is moving, making big strides. In fact, 10 years from now, we'll be looking back and thinking, oh my God, how primitive were we in the use of immunotherapy and how much distance we have covered now. So there is a lot to look forward to. In terms of resources, there is plenty of them. The American Cancer Society and the National Cancer Institute provide very high quality information when we want to know about cancers. And also, when we look at the level of patient advocate level, also there are resources for that. And then there are cancer support helplines, which can be quite useful. And also there is this support network and website called Frankly Speaking About Cancer. And obviously Gilda's Club here plays a very significant role in our local community to support our cancer patients. And they are definitely your immediate resource that can help connect you for other options as well. And one of the things that they do is this cancer experience registry. Now, as I said, research plays a significant role in improving cancer care, and also understanding not just the treatment needs for patients, but also their emotional and social needs is very important. And that's what this registry tries to do. And it helps teach healthcare providers like me what may be important and how for our patients and how best can we support them. And so this has been an ongoing registry looking at a variety of cancer types. And if you're interested and enough to consider joining on this, participating in this registry, this is the web link for that, the cancerexperienceregistry.org. And obviously you'll have to review that. There is an informed consent, which you have to read through and make sure that's essentially what you want to do. And also the Gildas Club offers other support programs, including the cancer support community and the grassroots movement, which you can be a part of. And there are other like the mylifeline.org. So with that, I come to the end of my presentation. Thank you for patiently listening to what I had to say, and I'm now open to answering any questions.